Hello, I'm Antoine Sauguet. I'm acting as interventional cardiologist, but more dedicated for peripheral interventions. And today we have the discussion of the patient with a critical limb ischemia. And I'm with Thomas Zeller to discuss for this fact. And my first question, Thomas, is what was your strategy for the critical limb ischemia patient?
Well, basically, the strategy for CLI patients in our institution is to go for endovascular revascularization first. The basis of everything, obviously, is best medical treatment, so that means controlling the risk factors and pain relief. But in terms of revascularization, we are following the approach of tackling occluded vessels by endovascular means, and if we fail, then we will refer the patient to the surgeon.
You mean, Thomas, that due to the diabetic patient, increased patient who are diabetic, there is an increased number of occlusive disease for the BTK, for example, and very long disease, sometimes without plantar arch patency, and it's not possible to perform some open surgery, and we go for an endovascular strategy.
Yeah, basically the different disease pattern is one of the reasons why we are moving into the endo strategy. The other aspect is that endovascular techniques did improve so much in the last 10 or 15 years. We have now low profile devices available. We have dedicated wires, balloons, stents, which are, by the way, coming from coronary procedures. So we are applying a lot of coronary techniques to below the knee interventions. And this, besides the different kind of pathology behind CLI, is one of the reasons why also the societies are in the meantime recommending in the vast majority the endovascular approach as a first line approach. And surgeries should be reserved to optimal anatomical conditions, meaning good outflow, good foot artery outflow, where the target for the distal landing zone is optimal.
And we know that there is some big evolution for the coronary arteries. Is there the same evolution for BTK lesion, BTK recanalisations?
Basically it is, well, with endovascular interventions in the periphery, we are about 1 decade behind the coronary development, meaning drug-eluting stents have become standard of care since 10-15 years in the coronary interventions. They are getting now also, or they are becoming at least a good treatment option for focal lesions. The major difference between coronary procedures and BTK procedures is basically the length of the target vessel and the target lesion. So what fits for coronary interventions, drug-eluting stents for example, does not essentially cover the entire needs of the periphery because we have limited drug-eluting stent lengths available, and these are probably only suitable for short lesions. And what we are still searching for is an optimal solution to treat long diffuse lesions in the BTK vessel segment.
My final question will be on the use of a drug-coated balloon, and what do you think for the future? Could we attain the same result as the femoropopliteal angioplasty with the drug-coated balloon, yes or not, for the BTK lesions?
Well, currently we have large-scale studies showing clearly that drug-eluting balloons are effective in the femoropopliteal vessel segment in prevention of restenosis. For below the knee, data are inconclusive. Initially, we had some nice single-center data, while suggesting at the end that drug-eluting balloons are as effective also below the knee as they are above the knee. But the only prospective randomized multicenter controlled trial which is finished so far, the IMPACT DEEP trial, showed the opposite. So there was no benefit for the drug-eluting balloon which was tested in this vessel area. So we are still in the position that we have to explore the performance of drug-eluting balloons below the knee because they would be a very attractive solution to deal with long diffuse lesions below the knee.
Thank you, Thomas. Thank you for all this answer on open question concerning the patient with CLI. Thank you.
You're welcome.